All right, we still have everyone kind of trickling in still, but for sake of time, we will get started. So thanks everyone for joining us tonight. Tonight's lecture will be given by Dr. Lauren Bernice. She is a board certified fellowship trained sports medicine physician specializing in sports and musculoskeletal injuries. Dr. Bernice treats a variety of patients, whether they be high school athletes, weekend warriors, or mature patients trying to keep active and stay healthy. Her practice focuses on a variety of injuries from acute to chronic musculoskeletal and overuse injuries, concussion, arthritis, and injury prevention, among other things. She takes a minimalist approach, focusing on overall health and exercise before jumping into interventional techniques. In addition to utilizing ultrasound for injection procedures and regenerative therapies, she conducts EMG testing for nerve and orthopedic issues. So without further ado, Dr. Bernice will take it from here. I think she's having camera issues, so we won't be able to see her face, but no, she has a great presentation for us this evening. And if you have any questions throughout, just please enter them in the Q&A box at the bottom of your screen. And Dr. Bernice will take some time at the end to get those questions answered.
Okay. Thank you very much, Natalie. And welcome everyone to today's Rothman community lecture. Thank you for taking the time to spend the next hour or so with us. I apologize again about my camera, that it's not working. You can see my picture on the Rothman website though. So today's topic we're talking about is called sacroiliac joint pain from diagnosis to treatment. And this is something that maybe some of you have never even heard of, sacroiliac joint, and some of you are all too familiar with. So we're going to be talking about, this is one of the very common causes of back pain and how it's so often overlooked. And we'll explain sort of how you make the diagnosis, how you treat it, and how you prevent it from worsening. The reason why I chose to speak on this topic is actually at my last practice, this is something I saw quite often. Someone would come in with low back pain or hip pain, but they would ultimately be diagnosed with sacroiliac joint pain. So I think it's something that's important for other people in the community to be aware of. And sometimes that something that looks like back pain or hip pain might not be that. So nothing to disclose. And I know Natalie just introduced me, but just a little bit about me, that I'm actually from this area originally. I went to medical school in Philadelphia at the osteopathic school, spent an extra year there doing a osteopathic teaching fellowship, did my residency out in Chicago in what's called physical medicine and rehab, or physiatry. And then I spent an extra year of training in sports medicine with a strong focus on ultrasound out at Swedish in Seattle. I continued on working there for another 3 years. Had a very variety of my practice. It was a lot of osteopathic manual therapy, procedural and diagnostic ultrasound, nerve conduction studies, and then just general sports medicine and management of people with back and neck pain. I also taught our sports medicine fellows out there. Recently moved back to the area when we decided to have our second kid. So we're closer to family, and I joined on with Rothman recently. And so my practice here is mostly sports medicine, but I also do see people with back and neck pain. I do a lot of procedural ultrasound, and then I still do a lot of electrodiagnostic testing for things like carpal tunnel and sciatica or pinched nerve in the back or the neck. So this is the overview of what we're going to be talking about tonight. I'm going to leave some time at the end, as Natalie has stated, for questions. It'll be a pretty quick introduction to this topic, and happy to answer any more questions at the end. Our objectives today, one is to understand common presentation of SI joint pain. And you'll see I'll label SI joint as SIJ just to make it easier. Understand how SI joint pain is diagnosed. Understand the typical management of SI joint pain. And review some exercises that you can do at home for SI joint pain to see if that's helping you before you maybe need to see a physician. Before I get started, just want to talk in general about low back pain. I'm sure some of you have already attended other lectures by some of my colleagues on low back pain. You might know that it's one of the most common reasons to see a physician just in general, and then also here at Rothman. As we age, more and more people have episodes of low back pain with an estimated lifetime prevalence of around 70%. It's also a leading cause of activity limitation and work absence, and it has a very large cost personally and on the economic in an economy. Unfortunately, despite it being so common, we still have actually very little understanding about the different causes of low back pain. So this next slide is something I created just to show how many different things can cause back pain. Now, granted, some of these are repeated in here for a fact, but there's so many different causes. You can have an acute muscle spasm, a ligament strain, fascia, which is the connective tissue. You can get changes in that. You can have pain from the vertebral bone, the lumbar facets, whole host of things. What we're going to focus on today is that sacroiliac joint. And that's typically present or a cause of chronic low back pain in about 15 to 30% of patients. And so chronic back pain means greater than 3 months of back pain. Other main causes are going to be your disc and then the joints in the small of the back called the lumbar facet joints. So before we even get further into what SI joint pain actually is, I want to talk about what is the SI joint, because some of you might still be saying, what are you even talking about? I know about the back, I know about the hip, but what's the SI joint? So the SI joint, or sacroiliac joint, is what's called a diarthrodial joint, where two bones come together to form a joint. It's made up by the sacrum, which is the base of your spine, and then the ilium, which is a part of your pelvis, larger part of the pelvis. This anatomy of this joint varies over time. So when we start out when we're younger, it's a nice, smooth, small joint. And then as we age, it gets ridges in there and it gets a lot of fibrous connections to help give it stability. So we're going to go a little bit more into the anatomy of this before we talk further on SI joint pain. So the function of this is to connect the spine to the pelvis and to transfer load. So meaning transfer load from the legs up to the body and to give stability. This is through the joint design. So as you can see here, there's a couple of parts of the joint, and some of it's more fibrous than other. And there's ligaments that help hold the joint in place, which are here. Many ligaments, as you can see, and these are thought to be a source of the pain. So you've got in the back, you've got these large ligaments connecting the back of the ilium all the way down to, these are your sits bones down here. And this is called the dorsal sacroiliac ligament. And this is an important part of when I'm examining a patient, if I'm looking for tenderness in here. And then you've got some smaller ligaments throughout connecting the sacrum to the ilium. And then in the front of the joint as well, there are also other ligaments. As you can see here, this is looking down sort of into the pelvis, and there's ligaments on the front of the joint. And then there's a lot of muscles that help give stability further to this joint. So here in this picture, you can see there's muscles coming from the back called your erector spinae muscles. There's muscles coming from the hip and the thigh, which is called your gluteus maximus muscle. And some of you might be familiar with the muscle called your piriformis that connects your sacrum to your leg bone. And that's a small little muscle deep in your buttocks that some people will have a lot of pain of this muscle, or it can get a spasm and cause what's called sciatica. And then there's even more muscles, as you can see here. All of these muscles listed here can affect the SI joint. So I'll just give you a second to sort of look at some of those. What's important to note is there's this muscle here, your gluteus medius muscle, and here, this muscle right here is your gluteus minimus muscle. These muscles are key in giving stability to what we call the lumbopelvic region, the lumbar spine and the pelvis. So these muscles help control the hip, help control the SI joint and the sacrum, and they're really important to give stability to prevent any issues at the SI joint or the low back. Not going to go into too much detail on the movement of the sacrum, but do know that there's very limited motion, maybe only several degrees. Many studies have looked at this. Some have said there's only a half a degree of movement. Some say up to 6 degrees of movement. And so the sacrum, typically when we're sitting or standing, it can tilt forward a little bit or it can tilt backward a little bit. And that's called nutation and counternutation. Then there's another motion of the sacrum, which is actually almost like when you walk, it's going to turn to the left, it's going to turn to the right a little bit on what's called an axis. I'm an osteopath, as I noted earlier, and we do a lot of manual therapy. So we're looking to see if someone gets stuck in one of these positions. Instead of normally when you walk, rotating from left to right, you might get stuck just being in the left position. Or going back to the nutation and counternutation, you might get stuck a little forward or stuck a little back, and that's thought to be a source of pain. So again, I've sort of mentioned the SI joint is meant to be stable. So the goal of this is to transfer load from the leg up to the rest of the body, but to dampen it. It acts as like a shock absorber. And so otherwise, if you didn't have this SI joint, all of the forces from the leg coming up to the body would be focused around what's called our L5 and our S1 disc. And then people would get significant arthritis in this area and disc issues. And so the idea of the SI joint is to distribute it a little bit more evenly throughout the lumbar spine to prevent this issue at the L5-S1 region. Additionally, when there's stability at the SI joint, it gives the hips a more optimal chance to work. If the SI joint is stable, the muscles that attach to that region then function at a proper, what is called a length tension curve. And so if the muscle is too overstretched, it's not going to work. If it's too shortened, it's not going to work. So the SI joint helps to hold it in a normal alignment and a normal length. Also, if the SI joint is either too stiff or too hypermobile, meaning it moves too much, it's going to alter gait. I'm going to very briefly talk about the innervation. This is probably above the scope of the lecture, but do know that there's typically thought to be 3 nerves, the S1, S2, and S3 nerves that give innervation to the sacroiliac joint. And these nerves can be used later on, as we'll talk about, to help treat pain from it. So what actually causes SI joint pain? There are many, many causes, and we're going to go through a few of these. The main cause, unfortunately, though, is what's called idiopathic. Idiopathic means we don't actually really know what's causing the pain. Someone just suddenly develops this insidious onset or slow onset of pain in the buttocks area, and they're eventually diagnosed with SI joint pain, and they don't usually have an idea of what actually caused it. However, then there are sometimes traumatic causes, meaning someone might fall directly onto the buttocks. Typically, it's falling onto one side more than the other. So there's what we call a shear force through the SI joint. Someone might be lifting a heavy box and their sacrum might get stuck forward just in 1 or 2 degrees forward, more so than it normally is. And that can cause tension on the sacroiliac ligaments, can change the muscles, and can cause pain. Another common thing that might cause it is, and I see this quite frequently, is someone might miss a step. So their one leg might get jarred up, and that again causes that shearing effect through the SI joint. This is also similar with a car accident. If someone's foot was on the brake or the gas pedal, either one, and the car gets hit from behind, the body goes forward, but that leg is static because of the foot being blocked, and that can put a shearing force through the SI joint. So other causes are what we call as atraumatic, or something not actually being trauma causing it, but these small little cumulative injuries to the SI joint. So this is something that might be in someone who has a biomechanical disadvantage, such as scoliosis. So when you have scoliosis, you've got a curvature of your spine. And so that might change how you put pressure through each side of the SI joint. You also might have something called a leg length discrepancy. This is typically what we call functional, meaning there might just be one tight muscle on a side making a leg appear slightly shorter, or you might have an actual leg length discrepancy where one of the bones in the legs is longer than the other side, causing this imbalance. Similar to scoliosis, this is going to cause abnormal forces through the SI joints. And another thing is a lumbar fusion. So I often see SI joint pain in people who had an L5S1 fusion or L4, L5, L5S1 fusion in the past, did really well with their surgery, not having back pain any longer. And then suddenly a couple of years later, maybe they start having low back pain or buttocks pain, pain in the proximal thighs. And often then I think, okay, is there something wrong with the hardware? You usually get x-rays, say the hardware looks really good in the back. It's likely not the fusion. Then you start looking a little bit more at the sacroiliac joints and saying, oh, maybe this is the cause of the pain. And most often not, it is actually the cause in someone who's had prior history of the fusion. This is because if you fuse an area above, the area below them might get more shear through it or more movement, and then causing increased likelihood of having injury there. Another thing that's very common is SI joint pain during pregnancy. Typically occurs during the 3rd trimester. This is typically due to relaxin, which is a hormone that's circulated throughout the body that helps prepare the body to deliver the baby through the pelvis. Relaxin is thought to possibly weaken some of the ligaments, or at least allow them to stretch out a little bit more. And then the other thing is just the pregnant body. You have extra stress from the front because of you develop a larger stomach or belly, and then the back you get a sway back, and that puts a lot of stress on the SI joints because the sacrum tilts forward and is pulling on those big dorsal sacroiliac ligaments. Something else is postpartum, after you've had the baby. Some women are doing fine, no back pain, and then shortly thereafter, maybe a couple of weeks later, they start having SI joint pain. That's because that relaxin actually stays in the body for a long time after having the baby, and especially women that are breastfeeding still have continued ligamentous, what we call ligamentous laxity, so allowing a little bit more movement at the sacroiliac joint. Other causes, which could have a whole nother lecture on its own, is called inflammatory arthropathies. So this is something just your general osteoarthritis or degenerative wear and tear of this joint. But there's something else called a spondyloarthropathy, or something called ankylosing spondylitis. Ankylosing spondylitis is where you actually develop fusion or loss of joint space between the sacroiliac joints, and this can ascend up the spine or go up the spine. This is typically seen in young males. So it's typically a young male who's in their late teens, early 20s, who's presenting with buttock pain and then starts to develop low back pain and significant stiffness. So I'll talk a little bit about making this diagnosis, but this doesn't apply to usually the general population. It's usually a select group of people who have this that we're concerned about it. So now we've talked about what can cause SI joint pain, but now how do you actually know if your pain is due to the SI joint? Unfortunately, making a diagnosis of SI joint pain can be quite challenging and very confusing. This can lead to an inefficient or difficult treatment if the diagnosis is nonspecific. Say someone's just sent to a physical therapist for nonspecific low back pain. So we really want to do everything we can to say, Is the pain coming from the lumbar spine, the low back, or is it coming from the sacroiliac joint? So typically, as physicians, we're listening to a combination of what's called the history. So the patient comes in, tells us a few key points about what started their pain, what causes their pain to get worse, what makes their pain better. Then we also do a detailed physical exam. Sometimes we get imaging. Still, when it comes to the SI joint, at this point, we might not know if this is the cause of our pain. So fortunately, we have something called diagnostic injections, and we're going to talk about this. But this is really the only way you can confirm that your patient's symptoms are coming from the SI joint. So we're going to go through all of these in a little bit more detail over the next couple of slides. So when we're taking a history, we're looking for pertinent medical history or pertinent factors in the person's medical history that might say, oh, you might have an issue with your sacroiliac joint. So these are things like we just talked about, the spondyloarthropathy. So a young male who has a lot of low back pain and low back stiffness, we might be thinking they have something called ankylosing spondylitis, as I mentioned. Someone else might have arthritis. So this might be an older patient or a patient who is not necessarily older, but had a lot of trauma. And someone who's a little bit more stiff or hypomobile, meaning not a lot of motion. So as I said, the SI joint doesn't have a ton of play, a ton of motion in there, but it does have some, and you need to have some for when you're walking, bending, lifting, twisting. So someone who's more stiff might have more shear through the SI joint or pressure through the SI joint. Then we're also looking for someone who is more hypermobile. And I was talking about in pregnancy, how our ligaments get a little bit more lax or relaxed. So patients also might be ballerinas or really good at yoga. Those are people who are on the more hypermobile side, and they tend to have more sacroiliac joint pain, just because, again, those ligaments are getting extra stressors across them because they're not necessarily tight and doing their job. Then I'm listening next to, where is the pain? So this is why the SI joint pain is so difficult to make a diagnosis. This diagram to the right shows you in purple where the SI joint pain can refer to in the majority of patients. So the darker purple means the majority of patients, and then as it gets lighter, some patients will report pain. So 94% of patients will say it hurts in my butt. That's basically what people come in saying. I have pain in my butt or in my glutes. And then 72% of people will also have some low back pain. Less people will have groin pain. That means pain in the very front of your hip. Typically, when we hear someone having groin pain, we are thinking it's actually a hip joint issue. But as you can see, there are 14% of people with SI joint pain that will have groin pain. About 50% of pain will have pain radiating down into their thigh. Typically, it's on the side or the back of the thigh. And then about 28% of people will have pain that goes past the knee. When I said the lower leg there, it means past the knee. Very rarely will it go into the foot. Again, that's about 14% of people. So just look at this pattern again. If you have pain that's typically in the low back, the buttocks region, that radiates sort of to those gluteal folds right around your sits bone area, and maybe into what we call the proximal posterior thigh, the backs of the thigh, that can be your SI joint. And it's more common in your SI joint than anywhere else based on these statistics. Then we're looking for, what does the pain actually feel like? Most people will say it's sort of this dull, achy pain, but then when they do something, if they get out of a car, it might become sharp or stabbing. Or if they walk and take too hard of a step, it might stab through their buttocks area. Very rarely, but sometimes people will complain of some numbness in the legs as well. But again, it's typically not going down the entire leg to the foot. It's usually more in that thigh area or maybe the proximal part of the lower leg just below the knee. Then we're looking for other things that might suggest that there's an imbalance or weakness in the pelvic area. And so I look for, I ask people about their urinary status. So do they go a lot? Do they have what's called stress or urge incontinence? If they cough or sneeze, do they dribble, lose a little urine? Or do they gotta go type thing? The reason why I'm asking these questions is sometimes if your pelvic floor muscles are weak, then it can affect how your SI joint stability is, and that can predispose you to having SI joint pain. Or vice versa, if you have SI joint pain, it might affect how you actually use those pelvic floor muscles and lead to then having this urge or stress incontinence. What I find most important is what really makes your pain worse. This is helpful for differentiating between back pain, meaning like a disc, a muscle, the facet joints, or hip pain, or this SI joint pain. Most of the time, the sacroiliac joint pain is made worse with what are called transitional movements. This is getting up out of a chair. This is getting out of a car, getting out of bed. People will complain of pain in my buttocks when doing these motions. Someone who's been sitting for a while or doing prolonged standing, they might feel like they have to shift their weight, can't stay on one leg for too long. Or if they're sitting, they might shift over to the other buttocks instead of putting weight through that SI joint on that side that's painful. Some people have trouble lying on that side of the SI joint that's bothering them. A lot of people are bothered by prolonged walking as well, where they're walking at first and they're okay, but as they keep walking and walking, they start getting this buttocks pain or low back pain, sometimes again radiating to the proximal part of the lower leg. Stairs can also be an issue just because of that shearing force through the SI joint as you're going up the stairs and putting pressure from the hip to the SI joint to the low back. Then a lot of people will complain of pain when they bend forward because that SI joint might just not move as smoothly as it's supposed to. And then alleviating factors, there's not much in the literature that says what goes along with, what alleviating factor suggests it's the SI joint pain. Most commonly, again, I just hear people saying, I shift my weight to the other side and I feel a little bit better. So to put this all together, the history, I just want to talk about an example patient. This is someone that I might be seeing coming into my clinic that I'm going to be thinking, this is likely the SI joint and not necessarily a disc in the back or a hip joint issue. So here's the example. You guys can read with me, but it's a 34-year-old female, former ballerina and mother of two, with 2 years of intermittent low back pain who's presenting to your clinic. Pain is located in her buttocks and the low back. It's described as a deep, achy pain, but can sometimes be sharp and stabbing. Pain radiates into the buttocks, down the lateral and posterior thigh, and occasionally into the lower leg. She has occasional numbness in her left calf, but not into her foot. And she reports occasional stress urinary incontinence. Symptoms are worse with standing up after prolonged sitting, getting out of a car, and with prolonged standing. Symptoms are better with cracking my back. So this is a very common presentation of someone who I'd see, and I'd be thinking, I need to do more tests now looking at the SI joint. So now what tests exactly am I going to be doing? So I take a very thorough history, as I said, and then I examine the lumbar spine. So I'm looking for everyone who's coming in with buttock pain or low back pain. I'm doing a really detailed back exam, having them bend forward, backwards, twist, checking their strength in their legs, reflexes, their sensation. That tells me a lot about the back and the nerves in the back that go down the leg. But how can I really look at the SI joint? So I asked the patient, actually, simple test, point where it hurts. If the patient points above the hip bones, so if you actually put your hands on your hip bones, they're called your iliac crest, and point your thumbs towards your back. I hope you guys are all doing this with me. Where your thumbs are pointing towards in the back, there's these two little bumps in the small of your back. Those are called your PSIS, posterior superior iliac spine. Right at that level or below, if you have pain in that area, it's considered a positive Fortin finger test. So this was a physician who got to name this test after himself, and it's probably one of the most simple tests. If you point to that spot where the SI joint is and that causes you pain, it's a good likelihood that your pain's coming from there. If you point just above that bump in your small back, it's most likely coming from your lumbar spine. And then another thing in the exam, when I'm examining patients, I'm pushing on their back, feeling different structures, feeling the bones, feeling the ligaments, feeling the muscles. If people have tenderness over those ligaments that I was showing you, called your posterior or dorsal sacroiliac ligaments, then I'm thinking this is most likely SI joint pain. Those ligaments, again, they start actually at those small bumps in the back, those PSIs, and they go down towards the bottom of your buttocks. So it's sort of a linear line on both sides. And there's a lot of other exam maneuvers. I'm not going to go through all of these, but all the studies have shown that one of these being positive, meaning one of these reproducing your symptoms, is not enough to diagnose sacroiliac joint pain. You typically have to use 3 of these tests or have 3 of these tests positive to say this is most likely coming from your sacroiliac joint. So if you haven't gone by now, this is a hard diagnosis to make, and it takes an extensive exam and history taking. I'm just going to show you a couple of these different exam maneuvers. Something here called thigh thrust. We're just pushing from the femur back to the buttocks. Have my hand on that SI joint, and if you pan where my hand is, that might be coming from your SI joint. There's something called Patrick's or Faber's test, where we're putting stressors through the SI joint by bringing the leg into what's called flexion and abduction, sort of a figure 4 position. And if you have pain in the buttock, this is most likely your SI joint. If it's coming from pain in the front of the joint, or the hip joint, sorry, in the front and the groin, it's going to be your hip joint. And there's something called Gainsland's test, where we're putting shear through the SI joint and seeing if that causes pain. And then there's all these other tests listed here that I'm not going to go through today. So other things that I'm looking for when I'm examining a patient, as I said, I've already looked at the lumbar spine typically at this point. Then I also am looking for what could be contributing to what is likely SI joint pain. So I look at the leg lengths. I get just a gross idea of, is one hip higher than the other when they're standing, or when you're lying down, does one foot look like it's a little bit further down the exam table than the other? I look at the pelvis and I see, is one hip bone rotated forward a little bit more, or one rotated back a little bit more? Is one what we call flared out or flared in? I'm also looking at the lumbar spine for any restrictions in motion or a scoliosis. And then I might be testing someone for hypermobility. There's something I wrote here called benign hypermobility syndrome. This is a series of tests called Beighton criteria, where I'm examining people's elbows, fingers, wrists, knees, back, and seeing if they're really flexible. These, again, are your patients that are typically going to have been ballerinas or maybe are really good at yoga, people who can put their hands on the floor easily without having to bend their knees. People with benign hypermobility syndrome likely have a higher incidence of having SI joint pain just because of having less stability from their ligaments at the SI joint. So now we've done the history, we've done the physical exam. I'm now getting suspicious, say that you have SI joint pain. Am I going to order any imaging? To be honest with you, most of the time I do not order any imaging. This is typically a diagnosis that is made from the history, physical exam, and then, as I said, diagnostic tests. The reason to do imaging is if the diagnosis is still really not clear, or if I think there might be a pinched nerve in the back or arthritis in the back. I might be getting lumbar imaging, including an X-ray or an MRI. I might also be looking at the hip to see if there's really bad arthritis that could be often causing buttock pain. Even though I said it's more groin pain, sometimes it does cause buttock pain. Then if I'm concerned for one of those things that I was saying, the spondyloarthropathy or ankylosing spondylitis, I might be getting a pelvis X-ray to look for signs of inflammation. Or if someone really just doesn't have a lot of motion on one side of the SI joint, I might be looking for arthritis in that joint. Very rarely am I ordering labs for SI joint pain. But again, if it's a younger male in their 20s, and again, this can sometimes be someone else like a female, but younger male in their 20s, we're thinking something called ankylosing spondylitis. So we might be ordering labs here. And if they have a positive, what's called HLA-B27, I'll be sending them to a rheumatologist typically. So here is the main way to make a diagnosis. It's a diagnostic injection. So unfortunately, this test, to make a diagnosis, you typically have to stick a patient with a needle if you need to. Sometimes I just say, it's likely you have SI joint pain, let's treat it as though it's that. And if not, we can do this diagnostic test. So this test is typically done under what's called fluoroscopy guidance or X-ray guidance, where the patient's lying down on the table on their belly, and the provider then inserts a needle into the SI joint, injects a little bit of dye. As you can see in this picture, there's a little bit of gray signal where those arrows are, and that's showing an outline of the SI joint based on the dye. And that tells you that you're in the SI joint. Then you inject some anesthetic, something called like lidocaine. And the patient does something that bothers their symptoms. So typically if they're getting out of a car bothers their symptoms, or lying on their side, or doing those exam maneuvers that I said, they would do their symptoms. And if they have 75% or more relief of their pain, that's considered a positive diagnostic test. So that tells us it's likely pain coming from the SI joint. However, you typically require 2 of these to confirm your diagnosis. So where we're at, again, I'm going to keep going over this. History, physical exam leads us to this diagnosis. These diagnostic tests then tell us this is definitely where the pain's coming from. You can also do it under ultrasound guidance. And this is how I did these diagnostic injections at my last practice. I will say when you're doing under ultrasound guidance, you can't confirm that you're in the joint because we don't have that dye that you can see to confirm you're in the joint. But I can say that I'm in the ligament because I can see it being injected into the ligament and I can get a sense of if I'm in the joint. So I typically say this is almost as good as your fluoroscopy guided, and it requires no radiation. And it's pretty simple. You just come into my clinic, we do it, and the procedure is done in about 5 minutes, not even. It's typically only 5 minutes because I'm preparing for the injection. The injection itself takes about 10, 15 seconds. So we're thinking, again, it's the SI joint, but what could we be missing? So I've already mentioned the lumbar spine a few times. It could be a pinched nerve in the back. We're looking at this. These colors show different pinched nerves where they typically send their pain. So the pink one, the L5 nerve, and then the grayish tan one, or sorry, the orangish tan one, the S1 nerve, those can mimic SI joint pain. Another is the facet joint. The facet joint is a small joint in the low back. This, if you have arthritis in or inflammation, can reproduce similar symptoms. And again, this is showing the typical pain pattern for lower lumbar facet arthritis. You can have what's called a spondylolysis. I've not mentioned this yet, but it's a small fracture in the back. You can have hip joint pain. Again, most people with hip joint pain, it presents in the groin or the front of the hip, but sometimes it can represent in the buttocks. You can have something called greater trochanteric pain syndrome. This is pain from gluteal tendonitis or tendinopathy, and this is over the side of the hip. You can have what are called trigger points. These are painful areas in the muscle that when you push on that spot, it sends pain somewhere else. So there are different trigger points in the buttock muscles, specifically the gluteus medius and gluteus maximus muscles that can reproduce symptoms of SI joint pain. Less common are other things like an infection in the joint, fracture, malignancy or cancer, or referral from other sources. Someone with fibroids, like uterine fibroids or something, might refer pain in this pattern. So what do we do when we think that you have the diagnosis of an SI joint pain, either if you have or have not done the diagnostic injections? Typically, if we're non-pregnant, I put here non-inflammatory. The standard of treatment is to take anti-inflammatories, apply ice or heat to the painful area, modify your activity so you're not in one position for too long, start a course of physical therapy, consider some chiropractics, maybe orthotics if you have a leg length discrepancy, consider an SI joint belt, maybe do an injection, maybe do what's called an ablation where you block the nerves that are causing the pain, maybe go to a surgical fusion. I'm going to talk about what I actually do. So my approach for, again, non-pregnancy, non-inflammatory, someone with just sacroiliac joint pain, all about rehab. So I have someone go to rehab for a while because it takes a long time to work on stabilizing the muscles and the hips in this region. So I have people at first stretch out tight muscles for a couple of weeks. And once they've stretched out tight muscles, then I have them really focus on strengthening. Initially, it might be something very simple like activating your core muscles without holding your breath. Then it might be engaging your hip muscles called your gluteus medius muscles and your gluteus maximus muscles. And you work closely with a physical therapist who is comfortable working on the back and the hip area. Next, I might have them do activity modification. So if it hurts when they're running because they're putting a lot of force through that leg, I have them back off and maybe just do walking or run in a pool, somewhere where there's going to be less force through the SI joint. I might have them do a stationary bike or an elliptical, just something that doesn't cause pain. I want people to keep as active as they can, but avoiding further irritation to the area. Next, we might say try topical medications. So you might try a lidocaine patch or a lidoderm patch. You can try something called Voltaren cream, which is an anti-inflammatory cream, but I typically like to start more topical rather than taking a medicine by mouth, just because that goes more systemically. Sometimes though, these medications don't penetrate deep enough to improve symptoms. I'll also have them try ice and heat. Often if it just flared up, I'll have them do ice, but if this has been going on for a couple of months or a couple of years, I say probably heat might feel better, but really whatever feels best. Then next I have people do manual therapy and or acupuncture. Acupuncture has excellent evidence for, or good evidence, I should say, for treating chronic low back pain. And this includes the SI joint. And then also manual therapy. So seeing an osteopath, seeing a chiropractor, seeing a massage therapist can be helpful. Next, I like to talk to my patients about what's called a sacroiliac joint belt. This is put on the buttocks area across the hips, and it's tightened in the front of your pelvis area, and it gives stability to your SI joints. This typically helps in people who have more of the hypermobility cause of SI joint pain. And then at this point, now I'm talking about, should we try that diagnostic injection? Should we confirm this is our diagnosis? Sometimes I'm also putting steroid in there if I'm really certain that this is their cause of their pain. Put some steroid in, it's a strong anti-inflammatory that will give at least 3 months, or typically 3 months of benefit. They still have discomfort, then I'm getting them back into rehab, and I might even be sending them to a different place for rehab. Where I used to work, I worked with a lot of Pilates physical therapists, and so doing a course of Pilates with a physical therapist is usually quite helpful because that activates the pelvic floor muscles, the core muscles, the hip muscles, and really helps with SI joint pain. Very rarely am I sending someone for what's called the ablation. This ablation procedure, which we'll again talk about in a little more detail, blocks the nerve and the pain signals, and it can give about 1 year of pain relief. And I put here, I've yet to send someone for a fusion to this area. My concern is if you send someone for a fusion to your SI joints, what's going to happen to the lumbar spine then? Because as I said, this is supposed to act as a shock absorber for the lumbar spine. So if you fuse the SI joints, you might be looking at accelerating arthritis in the lumbar spine. So now if someone has pregnancy-related SI joint pain, what am I going to be doing? With them, I'm typically focusing on activity modification. So really avoiding those painful activities. Again, if someone's a runner or if someone sits a lot at their desk, I'll have them use a sit to stand desk and transition about every 30 minutes between sitting and standing. I'll get them into a good course of rehab, typically with a pelvic floor specialist or someone who's worked with women that are pregnant. I'll have them wear an SI joint belt because typically this is a more hypermobile type of SI joint pain, meaning again, there's more movement causing the discomfort. Then I might be offering them manual therapy. In my old practice, I did manual therapy. I'm not currently, so I'd have to refer to someone, but look for a good osteopath in the area. You can also do massage therapy. You can do gentle chiropractics, but when you're pregnant, I'm usually a little cautious with that. And then acupuncture is considered safe during pregnancy and can be quite helpful. So what are the goals of physical therapy? So if someone has more of the hypomobility type, like arthritis, or as I was saying, the spondyloarthropathies, or they had a lumbar fusion, or have a lot of lumbar arthritis, I'm going to be addressing those areas of restriction, trying to improve the mechanics and the mobility as best we can, and then address any tight muscles or tendons. So the hip flexor muscles, some people might be familiar with those, your iliopsoas muscles. If those are really tight, they actually pull your pelvis forward and can change the position of your sacrum, which then indirectly affects the position of the mobility at your SI joints. So working on stretching those out. I like to improve breathing because if there's tight muscles in the pelvic floor, breathing can actually help stretch those muscles out a little bit or improve the flexibility of those muscles. Also, I'd like to address strength deficits. This to me is the main focus. So working on strengthening the pelvic floor muscles, the core muscles, and the hip muscles. Working on what's called neuromuscular control. This is activation of the correct muscle at the right time. This is really specialized training with the physical therapist. This is something that's hard to get from just a home exercise program. And then we progress to sports-specific activities if this is someone's goal. So say someone was a runner and has SI joint pain with running. After they are doing well with their physical therapy, not having any tenderness any longer at their SI joint, then we get them in a return to run program. And then what is important is to learn a maintenance program for flexibility, strength, and stability. So I just want to go over a couple of exercises that people can do at home relatively safely without increasing their risk for injury. So main thing is focusing on hip stabilizers. So that again is your gluteus minimus muscle, your gluteus medius muscle, and then the smaller hip muscles that I showed earlier. So there's something called a wall press. This is where, I wish I had my camera on because I wanted to actually demonstrate these, but look, I have pictures here. So this is where you actually stand with one leg bent pressing against the wall and your other leg is straight below your hip. So your foot is in line with your hip. You're going to push your knee into the wall for about 5 seconds. And this is actually working the glute in the standing muscle leg. So the leg that's standing, that buttock muscle is being worked on and strengthened. This is a really safe exercise. There's very low risk of fall, low risk of hurting anything. Typically, I recommend you, again, hold for 5 seconds and do 10 repetitions on one side, switch to the other side, and then repeat and do 2 full sets. Here's another exercise that works that glute muscle. This is called a side lying hip abduction strengthening exercise. This is where you lie on your side, lift your leg up to the side, hold it for a couple of seconds and slowly lower it. This one is relatively safe to do. However, I do notice some people will tend to use their hip flexors. So you need to make sure your heel and your foot is in line with your hip or slightly behind. I sometimes even tell people to have a wall behind them and they slide their leg up the wall slightly and then hold and then slowly lower. Then there are TheraBand exercises where you get a resistance band and put it around your legs. And if you bring your leg out to the side or bring your leg back, you're strengthening different hip stabilizer muscles. And then here are some good core exercises. So what's called a side plank or a front plank. So the side plank is up top and then a front plank is located below in this picture. These exercises are really good for the core and the hip muscles. And while you're doing this, you want to make sure you're breathing as well. Some people will start holding their breath. My goal for people is to start, you can start on your knees if you need to, start at 15 seconds, do this 3 times. And over time, slowly increase it to 30-second holds 3 times. And then your goal is to get up to 1 minute, 3 sets of 1 minute. And I would recommend doing it on your forearms, that front plank, and then on your sides, do it on both sides. Don't just do it on the symptomatic side. And then other manual therapy exercises. So this is, you can go to a chiropractor, a massage therapist. I already briefly talked about acupuncture. Osteopathic manual therapy, I describe as sort of a mix of all the other types like chiropractics and massage and acupuncture, but without the needles. We're addressing tight muscles. We're trying to work on restrictions in bone, like bony restrictions. Also work on improving what's called the lymphatic flow to improve quality of drainage of toxins from the area. And then next is this SI joint belt. So this is an example, it's called a Sorolla belt. And so again, you can see in this picture, it's worn quite low around like the sides of the hips. And this is really helpful to give what we call force closure to the SI joints, to give that stability that maybe your muscles just aren't quite there yet to do, but over the course of physical therapy, you'll strengthen and be able to do it without the SI joint belt. And I also wrote in here kinesio tape. There's actually been a few studies, not too many, that have shown that taping of the low back can help improve the activation of the muscles and possibly give a little bit more stability indirectly to the SI joint. Injections here, I briefly mentioned steroids. So steroid injections can be done into the SI joint. These can be done under X-ray guidance or under ultrasound guidance. Evidence shows that you actually just need to get into the ligaments, probably not necessarily into the joints. So ultrasound guidance is just fine. And most people tend to do quite well with this. Some people, when the steroid wears off, will have a return of their pain. But if the physical therapy is working, oftentimes the pain doesn't return when the steroid wears off. You can also do something called platelet-rich plasma, or PRP. This is your own body's quote unquote healing cells, where you inject it into the area. It initially will cause an increase in pain for maybe a couple of days up to 2 weeks. And then over the course of about 4 to 6 weeks will significantly reduce symptoms. This is actually a cash pay because it still is under investigation, but does have pretty good evidence for some other body parts. There's something else called prolotherapy. This is where you inject actually sugar water, sterile sugar water called dextrose, into the ligaments. And this can help strengthen the ligaments and reduce pain. So it also causes an anti-inflammatory reaction after a couple of weeks. This requires a series of injections, typically 1 injection about every 3 or 4 weeks for about 2 to 4 injections. Then there's something called a radiofrequency ablation, again, where you block the nerve that goes to the SI joint. And this doesn't affect any motor control, it just purely is sensory. And this tends to last for about 9 months to a year. I'm just briefly going to talk on surgery. Most people are not referred to a surgeon. So this says who can go to a surgeon for this. Typically, if you've had symptoms for at least 6 months, you fail conservative treatment. That means you've tried the belt, you've tried activity modification, you've done your physical therapy, maybe you've had injections, you're just not getting better. You're having a lot of impairment of your daily activities, and you've had that confirmatory 2 diagnostic SI joint injections. Can go see a surgeon. Again, most surgeons aren't thrilled to operate on this because it causes other issues in the lumbar spine down the line. However, over time, the SI joint surgeries have become more minimally invasive and have reported about 80% success. So prognosis, unfortunately, many studies haven't looked at if you've had SI joint pain, how well are you going to do in the future? What I've found from my patients is that most people, if they keep up their home exercise program, maybe doing 3 or 4 days a week of strengthening exercises, their symptoms go away and don't really return. Often if symptoms are starting to return, I ask, are you still doing your exercises? And most of the time people will say, oh, I backed off a little, I was feeling so good. But if they start them back, they'll feel pretty good again. There have been some studies showing, though, that if you keep up this personalized stabilization exercises, that it will reduce disability from SI joint pain by at least 50%. So again, going over our objectives. So we want to talk about common presentation of SI joint pain. So we talked about it's typically in the buttocks, sometimes the low back, and sometimes can go to the lower extremities. So it's going to be often one or both sides of the low back, buttocks, reading to that proximal posterior thigh, sometimes to the proximal or just below the knee, lower leg. Often works with transitional movements like getting out of a car, unilateral weight-bearing exercises like running, or sometimes prolonged time spent sitting in one position. How is it diagnosed? As I said, it's quite complicated to diagnose. Typically, we're listening to the history and doing a couple of physical exam maneuvers, but we're confirming with an SI joint diagnostic injection if we need to. How is it typically managed? Multifaceted approach, meaning we're doing multiple things. We're doing physical therapy for strengthening. We're often doing manual therapy to relax tight muscles or decrease pain. And then we may or may not be doing injections. Then I want to go over some of those exercises for SI joint pain. So again, it's important to come up with a personalized program with your physical therapist, but I gave you a couple of those exercises that you can try on your own. So a few more take-home points is when you're looking at the SI joint, you need to first rule out other causes. If multiple exam tests suggest it's the SI joint pain, I want you to start your personalized physical therapy program. Consider that manual therapy, consider that SI joint belt. If you're not improving is when we go to those diagnostic injections. If it says, hey, this pain's coming from your SI joint, then we're going to look further. What else can we do to minimize stress through the SI joint and stabilize around it? If it does not confirm it, now we need to look back what other causes can contribute to symptoms in that area. And then if you're improving, choose a few exercises to maintain lifelong exercise to minimize these symptoms from coming back. So with that, sorry, I went a little bit over, but hopefully we have at least 15 minutes to answer some questions. I'm going to stop my share and see if I can see these questions.
Thanks, Dr. Bernice. I actually have one question that someone emailed me before, so I'll read that to you. And then do you see the Q&A box?
I do see the Q&A box, yes.
Okay, let's just start with the one that was emailed. So this person said, I have back and leg pain, feet are asleep in the night. Does a lidocaine patch damage nerves? Also, the creams such as Aspercream or others, what is the consequence?
That's a very good question. So the theory is that the lidocaine cream and patches, that they don't actually penetrate deep enough to even get to the nerves. So it's unlikely to be a cause of any nerve issues. The main side effects of lidocaine cream and the patches is, one is if you have like a topical allergic reaction, contact dermatitis, and two is just that it's really ineffective in some people if it doesn't penetrate deep enough. So as far as I'm aware, like lidocaine creams and patches don't penetrate deep enough. Obviously, if someone's very, very thin, that's potential to cause symptoms. If you have lidocaine injections, that's another story, because that's being injected around the nerve. Typically, an injection here or there is not going to bother, but over time, it can affect your nerve. Does that answer that?
Yes, thank you.
Okay. I'm going to read the questions that I have here. So here's a long question, so bear with me. But after falling, I had a lot of hip and back pain. I noticed my one SI joint would click when I go up the steps. Then I started having severe groin pain when I would go from the seated position to standing. Pain was so bad I was screaming pain. I had PT and epidurals. I went to a chiropractor who diagnosed me with SI joint dysfunction. Chiropractor helped. A few years later, I started having the same groin pain, but on my left side. MRI showed I had pinched nerve in my cervical, lumbar, and sacrum. Epidurals helped the cervical and lumbar pinched nerves, but epidurals did nothing for the pinched nerve in my sacrum. January, I had an ablation done and that helped, but I've been told it doesn't last. I notice I'm starting to get some of the groin pain back after sitting, and I try to stand. In the past, I had to use a cane and walker to stop me from falling. Can you help me? So one is I'd be happy to see you. Two is just, I think I can answer this question just for general, anyone else who's had similar symptoms, is that as you can see, it's like if you see stuff on the MRI in the lumbar spine, people will typically treat that first. But oftentimes the sacroiliac joint is still causing some of these symptoms. And it seems like in your case, it likely is. I would also want to rule out that the hip joint is causing your pain too, though. But for this, I want to ask is how much physical therapy have you done? Have you actually ever worked with a pelvic floor physical therapist? Because they can make sure that they're working on making sure muscles aren't too tight in the pelvic floor or too loose or not able to be activated. It's actually quite challenging to activate the muscles in your pelvic floor without holding your breath too tight. Or overusing your bigger muscles. So I think really looking at a good course of pelvic floor physical therapy would be beneficial. And then if not getting better, then trying the SI joint diagnostic injection and seeing if that helps. If that helps, then we can talk about different injectable options if you've already done the physical therapy for the SI joint. If it doesn't help, then looking more into is the hip joint actually causing some of your symptoms? And then you can also do diagnostic injections there or get further hip imaging. Regarding using a cane or a walker to stop from falling, I think that's a great idea. You can also try some things called trekking poles. But again, happy to see you if you can come to one of my clinics, but try working with a pelvic floor physical therapist if you haven't already done so, seeing if there's any imbalance in those muscles. And then again, considering diagnostic SI joint injection. Okay. Next question, how does arthritis impact the SI joint or does it? And as an osteopath, is there any over-the-counter medication? Oops, I just lost the question. Over medication you would recommend for this condition, Dr. Bernice. So how does arthritis impact the SI joint? After about the age of, it's even 40 or 50, actually, we can see the arthritis in the SI joints in people who do not have any pain. So we tend to think that as we get older, we get arthritis in these joints, but it doesn't actually cause symptoms. However, if you have a decent amount of arthritis or an asymmetric, meaning more arthritis on one side than the other, we might be thinking this is contributing. Typically what happens is when you have arthritis, you lose that space for the lubricating fluid in there. So it gets like things grind a little bit more in the SI joint. And it can also change how the SI joint moves and can cause strain on the ligaments. So arthritis can impact it. And arthritis in the lumbar spine can also impact it because if there's a lot of arthritis in the low back loses its flexibility, which puts more stress through the SI joints. I am limited on which medications I like to use for things because I find a lot of the anti-inflammatories might help temporarily, but in the long term are just sort of masking symptoms and not necessarily addressing the underlying condition. I do recommend people take turmeric or curcumin if they're allowed to. That's an anti-inflammatory supplement. And that can be quite helpful. Typically people will take about 500 milligrams twice a day, but you just read the bottle and take it. Often putting turmeric in your food or making smoothies and adding turmeric can be helpful. So I like that as it's typically well tolerated and there's not really many contraindications for using turmeric. But again, anti-inflammatories can be helpful. Tylenol, some people find muscle relaxers helpful, but they have a lot of side effects. So I try to save those only for if someone's having a really bad flare. Okay, next question. Is pain in the lower outside knee when placing weight in the area a symptom of SI joint pain? So I'm assuming this question means placing weight in like the leg. So typically if it's just at the outside of the knee, it wouldn't be coming from the SI joint. It would typically be traveling from the buttocks into the posterior thigh down to the side of the knee when it's coming from the SI joint. So you'd usually feel that connection. There is something called your iliotibial band, your IT band, that starts up at the side of the hip and goes down to the side of the knee. Sometimes people will have pain just at the origin of it, meaning the side of the hip, or at the knee. And so that can sometimes be something called, again, IT band syndrome. Often people with SI joint pain or dysfunction will have IT band syndrome. Sometimes their SI joint is too hypermobile, and then the IT band gets really tight and will pull on the knee. Okay, next is, I've tried Dr. Solomon's CBD THC transdermal lotion and it helps. That's a comment from someone that might help other people, so I like that. So again, I'm going to repeat that. It's Dr. Solomon's CBD THC transdermal lotion. I've not personally used that, but I've had other patients say that that stuff does help. How does one avoid an SI joint pain injury? So how to avoid getting SI joint pain? We can't really avoid injury if it's you miss a step or you're in a car accident, but how can we prevent development of SI joint pain? I really encourage people, even if you don't have discomfort, to keep up some of those exercises I showed to strengthen your gluteal muscles and your hip stabilizer muscles, and then those core muscles. So I really recommend people do some sideways exercises. So a lot of people are walkers or runners, and they just do forward exercises, which strengthens the front of the leg, your quadriceps, and the back of your legs, your hamstrings. But it doesn't really do a lot for that stability in the hip pelvic region. So doing sideways activities like putting a band around your legs and side walking, doing the wall press that I demonstrated, doing the sideline hip abduction, and then doing things like your forward planks and your side planks can be quite helpful and possibly prevent, I don't have any studies saying it will, but prevent development of SI joint pain. Other thing is to avoid staying in one position for too long period of time. That puts a lot of stress through your low back and your SI joints. Next question, is low back pain usually clearly either one thing or another, or can be a combo of SI joint and lumbar pain? That's a very good question. And most of the time I will tell you, I find it's a combination of the SI joint in the low back or the SI joint in the hip. So when I'm examining people, as I said, I'm looking at the low back, the SI joint, and the hip. I'm sort of looking at a joint above, a joint below. And often it's a combination. And this is because if one area becomes painful, becomes too mobile or too hypomobile, maybe more arthritis, it's going to impact forces being transmitted through one of those other areas. Again, the lumbar spine, the SI joint, or the hip. So it's often not clearly one thing. So when I do the diagnostic injections in patients, I have them keep a diary afterwards and say, okay, for the next 4 to 6 hours while that lidocaine's working, I want you to document how much did your pain improve, where did that pain improve, and what other symptoms were you having? And then that way we can tease out, okay, maybe some of your pain is from the SI joint, but maybe some of your pain is also coming from the low back. The good thing is MRIs of the low back typically show painful areas, like if there's a big disc bulge at the area where we're expecting, or if there's a pinched nerve, or if there's a lot of arthritis. However, sometimes we have these findings on MRI with no pain at all. So it's really putting together the whole picture. And again, going back to it, I also look at the hip joint as well. So does someone have a lot of arthritis in the hip joint? Because that transmits more forces then through the SI joint. Okay, next question. Follow-up, this was the last. If my pain is not clearly SI, perhaps hip or lumbar spine related, can I use the exercises you presented? Great question. Yes. So those exercises are sort of address everything, like the low back, the hip. You might need to modify things a little bit if it's one more than the other, but those are relatively safe exercises that can be done. Again, just caution with anything, but they're relatively safe exercises that can be done. And typically people are activating the correct muscle, but just be careful. That one that I was showing, that's called the sideline hip abduction, where you slide your leg up and down. If you bring your leg forward, you're going to be using the wrong muscle. So you want to have your leg in line with your body or slightly behind you. But these are really good for back pain, as well as hip pain and SI joint pain. Okay, another question. I have moderate arthritis in the hip. So hip groin pain in addition to SI joint symptoms, which can be intense. Am I a candidate for diagnostic tests? I swim laps a lot with no pain, but walking difficulty past few months. I love that you swim, first of all. I'm a huge proponent of getting in the water. I didn't mention this, but SI joint pain, swimming breaststroke or frog kicks can actually aggravate SI joint pain. So I typically recommend, if you have SI joint pain, either you swim freestyle where you flutter kick, or you put what's called a buoyancy cube between your legs, and then you just get a really good core and upper body workout. Another thing is getting in the water and walking can be really helpful. That was a side note. Back to your question. So having moderate hip arthritis in addition to SI joint pain, yes, you are a candidate for diagnostic injections, probably in both areas, the hip and the SI joint. You wouldn't do it on the same day, but it might give us an idea if traditional physical therapy is not helping. do we need to do more intense physical therapy targeting one area versus the other? However, again, as I mentioned, these often occur concomitantly, so treating one will treat the other. But doing diagnostic tests can sometimes help if it's not quite clear what exercises we need to do more so for one versus the other. Diagnostic tests, again, typically if you've done the physical therapy already, typically we say about 6 weeks of PT. Okay, next question. I had an L5-S1 laminectomy over 10 years ago. I still have low back and buttocks pain radiating to the right leg with numbness and pain. Injections didn't work for me anymore, and I do home exercise programs 5 days a week. Is there anything else I can do? So here's this is probably involves a little bit more detailed questioning, but if the pain resolved with L5-S1 laminectomy, but then it came back, then, this could be a few things. Did the hardware move? If the hardware is okay, is it more the SI joint? Or was there 2 things going on at the time? Maybe you still had symptoms after the procedure. Was there the L5-S1 issue, but then also the SI joint pain, and maybe you got part of it treated, but not all of it? So typically in this case, what I recommend, if you've addressed the back and you're just not getting better, is that then maybe we do go straight to the diagnostic SI joint injections to see if that is causing your symptoms, and then do the physical therapy instead of getting you back into PT because you've already been dealing with it for a while. So do the diagnostic injections. If it is from your SI joint, then saying, okay, let's get you to a specialist like a pelvic floor physical therapist, or a pelvic floor physical therapist who specializes in Pilates would be even the best. The other thing I do in the office is actually have you sometimes go over some of your home exercises to make sure you're not overusing certain muscles. Again, if you overuse your front of your legs, your quad muscles, you're actually shutting off the hip stabilizer muscles, those glute muscles, the ones that do sideways activation. So for you, I'd recommend considering, first of all, considering that diagnostic injection in the SI joint to see if it's causing your pain, and then maybe revisiting with physical therapist who specializes in this area to tweak some of your home exercises. Lastly, you can also consider what's called a nerve conduction study. I briefly mentioned this is something that I do called electrodiagnostic testing, or needle EMG. The needle EMG looks for if there's still an ongoing pinched nerve in the back, and that can tell us if some of your right leg pain is due to a nerve issue. If it's normal, then it's most likely coming more from a muscle or a joint or a ligament issue. There's just a thank you. Next question. Can drop foot have a cause involving SI joint pain? It's a very good question, and unfortunately, it would be extremely rare for this to be a cause of weakness of the foot. SI joint pain might cause a little weakness at the hip in like sideways testing or hip flexion testing just because of pain, but it typically doesn't actually cause weakness in the lower leg because it's not an actual nerve issue. It's more of a joint pain or a ligament pain or an imbalance in the muscles. However, if your SI joint is really out of alignment, which is very rare, but if it's really out of alignment, pulling on that piriformis muscle, it can affect how your sciatic nerve works. Theoretically, it could potentially cause a little weakness in the foot, but I wouldn't actually expect a drop foot from that. So that I would expect to be coming from the back or the sciatic nerve, or it's called your fibular nerve, which is around your knee. That can be teased out with an exam or an EMG, the nerve study. Okay, next question. I think we have a couple minutes. So being a physical therapist for many years, I've noticed that crossing the knees while sitting is one of the big reasons for SI joint dysfunction. That is wonderful. It is so true, because if you're doing this repetitive, that's one of the things I would consider a repetitive micro trauma. You're pulling your pelvis into a different alignment than it's normally supposed to be. You're also sometimes stretching out some of the ligaments on the one side, and then you're compressing the joint on the other side. So it can actually cause pain in either side. But that's a really good point. And then the other thing is people who sit cross-legged, or what used to be called Indian style. I apologize, I don't remember the new term for that, but sitting Indian style can cause a lot of discomfort in the low back and the SI joints, just because of putting extra stressors into the SI joints and putting different tension on the ligaments. So that's a great point. Thank you for that. Okay, someone was asking about, will the presentation be available again? I believe this is available to anyone who signed up for this lecture later on, and I'll let Natalie chime in if that's incorrect.
Yes, so we did record this, and I will send it out to anyone who registered probably within a few days.
Okay, great. And I think we have 3 quick other questions, then we'll be done. Does cortisone or lidocaine damage cartilage or bone? Very good question. The answer is most likely. If you do too many steroid injections, the steroid is thought to weaken the cartilage. So over time, we would typically recommend no more than 3 injections a year, which is actually based on insurance. I typically recommend not even 3 injections a year because of current evidence suggesting that over the course of about 2 years, too many injections can weaken the cartilage. It can also weaken the tendons and the ligaments around the area that we're injecting, because not all the medicine stays exactly where it is. So I am a little bit more conservative on my steroid injections. I tend to save them for the first time we do an injection. And then if you have a lot of pain that you just can't tolerate, physical therapy, exercise, whatever, going on a big trip. Another question is about lidocaine. Can lidocaine damage cartilage or bone? Studies, again, more recently are showing that some of these anesthetics also have a negative impact on the cartilage over time. Some of my old colleagues out in Seattle where I used to work actually were starting to notice some issues with when they're doing shoulder replacements or tendon repairs, that if someone's had multiple shoulder injections, that the tendon repairs didn't come out quite as good, or the shoulder replacements weren't quite as good. So there's probably other things going on besides just the cartilage itself. So again, I try to limit how many steroid injections we do. 1 or 2 here or there is typically considered safe, but I try to limit doing too many too often. So we have different injectable options that we can talk about. I have pain down my leg, and I'm told it is from this, or from B, it says, I'm assuming from back. So pain down the leg, again, can have many different causes. It can be a pinched nerve in the back. It can be referred just from the back, the joints in the back, and it can be from the SI joint. Sometimes it can be from a pinched nerve in the buttocks area. There's many different causes, and the best way to tease it out is through history, physical exam, possibly diagnostic injections, possibly MRI to rule out like a pinched nerve in the back. Lower back arthritis, steroids not helping. Any more options, PT makes it worse. So this is something that, again, involves a little bit more detailed conversation. I feel like if you're doing the steroids and they're just not helping, I would just stop it at that point. I would probably be looking in your case at the SI joints and seeing, is this more causing your pain? Or is it just, unfortunately, that, you know, you have a lot of arthritis in the back and the steroids just aren't treating it because it's more degenerative rather than an inflammatory cause? There are other newer injection options coming out that are blocking pain from the bone in the back rather than the nerves. So that's what steroids are typically used for, the nerves. So there are some other options. So come in and meet myself or one of my spine colleagues. And thank yous. And what's your opinion on PRP injections? I think that's going to be our last question for the day. Here's the thing. I had a lot of training. My fellowship was very PRP heavy. So I've seen a lot of clinical benefit from it. The studies, unfortunately, do not really support PRP in many other areas besides the knee joint. Newer studies are coming out, but I should clarify, knee joint and also something called tennis elbow or common extensor tendinopathy. So when you're looking at the knee joint, PRP is actually found to be more beneficial than cortisone and what are called gel shots or visco injections in the long term. Steroids last about 2 to 3 months. Visco injections last about 6 months, versus PRP injections are shown to last about 9 months to a year. They don't tend to give as robust a response, so pain doesn't cut as drastically, but they work fairly well with really minimal negative impact. Only thing is on the pocketbook, it's about, can't recall, but about $12.50, I think. So it's quite expensive, but $12.51 or something around there. Price is changing, so we always just ask you to ask before you actually go ahead with the injection. I find for the SI joints, it can be helpful if someone has like small ligament tears in their sacroiliac joint region, or if they have just mild amount of arthritis. If you have a lot of arthritis, PRP is actually not shown to be very beneficial. So typically I reserve this for more ligament tendon issues or in mild to moderate arthritis cases. But PRP injections, again, I see a lot of clinical benefit from it. The literature doesn't necessarily support it except for the knee and then the elbow area. Okay. I think that's it, Natalie.
All right, awesome. Thank you so much for a great presentation and answering all of those questions. Dr. Vernice, thank you all for taking some time this evening to spend with us. You all have my email. If you are interested in making an appointment with Dr. Vernice, please reach out to me directly, and I'm happy to help get that set up for you. You don't have to call the 800 number. Happy to assist with that. And as mentioned, we did record this. It will be sent out to anyone who registered and attended this evening. Just give us 3 to 5 days and I'll get that sent out to you.
And thank you all for your time and spending the evening with me. I appreciate it, and very good questions.
Thank you so much. Everyone have a great night. Thanks, Dr. Vernice.
Bye.